Good morning. This is my first time being here as a older guy or younger guy. I really learned a lot, so I appreciate being here. So I don't know how my talk fits in the grand scheme of the session, but I'm going to talk about what I was asked to talk about, using large data sets for a research career. So when I got this assignment, I sort of broke this down into two parts. Using large data sets, that's kind of easy to talk about. But the second part, for a research career, is sort of a killer. So I'll do what I can. And first thing to talk about is, what do you mean by a large data set? But when you talk about research career, my short answer is you need to do this with caution. So, trying to put up what picture I will use. I looked at a lot of Donald Trump pictures to see if there's something appropriate for this setting, but I didn't want to be too controversial. So what is a large data set? And for most of us, these are the characteristics that is associated with a large data set. First, largest data set is usually ready-made, available, in other words, secondary data set. So it's hard to create a primary data set, your own data set that would qualify as a large data set, that it remains true. However, you can also link larger data sets. Dr. El-Sarak is master of the SEER Medicare link data set. You can do more things by adding different features to your link data set. At SRTR, we're making a link with IMS, which is a pharmaceutical database, trying to answer the question of Hep C treatment with what happens in a waitlist data set. So that's the kind of novel thing that gives you more ability to do stuff. Large data set, is it always publicly available? Mostly they are available. Publicly available doesn't mean that they are free. Sometimes you have to pay for the data sets. That's sometimes very expensive. But some are proprietary. The insurance companies, they own their data sets, then they may not give it to you, depending on their agenda. Is large data set always administrative? A lot of large data sets are administrative because if you think about it, administrative data sets collect diagnosis information, CPT codes, and the charges and costs. So they generate that in the course of their usual business, but as researchers, we can take advantage of that. But some large data sets are not administrative. If you think about NHANES type of data sets, it's a survey data that are collected by CDC with a specific purpose of research. Large data sets tend to be hypothesis generating, you know all this, because they often lack data points that are needed to answer your specific questions. So depending on your question, the question that the data set is derived from may not be the exactly right one. So you end up not answering the question that you're raising. However, there are some questions you can answer with large data sets. So I'm going to give you an example of that. One thing up front to tell you is that it is extremely hard, if not impossible, to obtain sustainable R-type funding doing secondary data sets. I've been on study sections where these have been proposed, and they don't fare well, and it doesn't make sense. I was asked to talk about big data set analysis as well, and in a common English, big is smaller than large. Large is bigger than big, but in this setting, big data are bigger than large data set. So there are biological big data. It's the genomic, proteomic, metabolomic, metagenomic data sets that Dr. Camilleri talked about briefly last night. And then there's social big data sets that we haven't been taking advantage of, but I can see this really taking off as people get more familiar with the methodologies. So, Google generates like 1,000-fold of terabyte is like petabyte or something that every day. Facebook's the same, Amazon, mobile phone, things like that. If you imagine those data sets linking to people's health behavior, health outcome, you can think about wild projects. So that's to come. These are some of the examples used in large data sets. Most common things are discharges. And then CDC collects mortality data set. There are many health behavior data sets that you can get. SEER is an example of cancer data set. UNOS has a transplant data set. Outpatient stuff is hard to get administratively, but there's outpatient surgery data you can get. Pharmacy we talked about. And many health systems like Kaiser and other insurance carriers have health system-wise and claims data sets. So there are many different kinds, and I will not list all of those things. You can find them on the internet. This is an example of data sets that can be used for your projects. This is part of the reason I'm showing this is the Phil Okafor is going to be our most junior faculty. But anyway, OPTN, as you know, it's a UNOS data set for transplant patients. This was one of the behavior risk factor surveillance system, the CDC. And alcohol research, you can do a lot of questions here. NHANES data set you should be familiar with. And then National Hospital Ambulatory Medical Care Survey. Again, outpatient stuff is hard to get. This is outpatient practice associated with hospitals. So you can get some data. This is a U.S. physician survey. NHIS is similar to NHANES, but different, more concentrating on medical care part. MEPS gives you, expenditure data. And SEER is a cancer patient data set. And then National Surgical Quality Improvement Program is a surgical patient data set that I haven't seen this being used in GI too widely. And then Nationwide Inpatient Sample is a part of Healthcare Cost and Utilization Project that is maintained by AHRQ. So these are just partial list of things, but just wanted to give you some flavor of what are available and what can be done. So I'm going to give you a few examples of my projects. Some are bad ones, hopefully not illustrating some of the pros and cons of doing these things. So the first project that I'm going to talk about is real-life impact of hepatorenal syndrome. And I used the nationwide inpatient sample, which was the last example in the last table. This is the largest all-payer inpatient care database in the U.S., has huge number of hospital stays, discharge records every year. It represents about 90% of all discharges in the U.S. It contains 1,000 or more acute care hospitals in approximately 40 states. So it's very representative. It allows projection to nationwide hospitalization based on the 20% sample it has. So it has number of strata, cluster, and discharge weights. They calculate how a patient is representative of the patient's universe in general. So if a patient record has a weight of 5, that means there are 5 such patients in the record, but what this one patient is representative. So if you multiply 5 to that record, then you get the 5 patients' data. That's the idea. So you can get the national data back to, projected back to the universe of the data. There are elements of a typical administrative data sets, demographics, diagnosis, procedure codes, and the outcome data, inpatient death, length of stay, charges, things like that. So as we look at the renal complications of cirrhosis hospitalization, we first needed to define what do I mean by cirrhosis hospitalization. And we looked at the diagnostic codes, and we said liver cirrhosis, portal hypertension, hepatorenal syndrome, hepatic coma, esophageal varices, ascites. If these are mentioned in the diagnosis, then I'm going to say these are cirrhosis discharges. And we found about 100,000 of those records. So you can think about a table with 100,000 rows. So this qualifies as a large data set in my mind. And that projected out to 550,000 hospitalizations. I think this was the 2008 data. So first caveat is this is a rule that I made. So whether this truly captures everyone that has cirrhosis, I'm sure it doesn't. The other is also true, whether patients that we missed, and I'm sure we missed. So that's the one caveat. But when we did the analysis, hepatorenal syndrome was present in 23,000 records, and hemodialysis was reported in 28,000 records, and about 5,000 records, they had both. So right off the bat, 20% of hepatorenal syndrome patients being dialyzed. That may make face validity, but 20% of hemodialysis in cirrhosis hospitalization having hepatorenal syndrome, that to me sounded low. But there was no other way to resolve that. So this is, I'm just telling you that the downside of this kind of analysis. We looked at the inpatient fatality rate and transfer to nursing home type of setting. And what you find is hepatorenal syndrome without, with, the same thing, and the darker bars are hemodialysis and lighter bars without. So for mortality, it's driven by hepatorenal syndrome or not. And whether the person had hepatorenal syndrome and had dialysis didn't seem to matter that much. If you carry the diagnosis, it's a bad thing. 40% mortality. Not going home to transfer to skilled nursing facility is 2/3 of the population. So this is a huge impact, as you can imagine, with or without dialysis. And then we looked at the economic outcomes. We looked at the length of stay and hospitalization charges. And here it is the hemodialysis that drove the thing. So if you are dialyzed, whether you had hepatorenal or not, it didn't matter. I mean, there was a gradation according to the hepatorenal syndrome, but dialysis was a big driver. In patients who had hepatorenal syndrome and dialysis, their average charges was $200,000. So again, this is huge. What you don't see in my figures is p-values. This is just a reminder to talk about p-values in the next couple of slides. So I hope I showed some of the pros and cons with the example of database research. This was immediately available. I could just purchase it. It's less than $1,000 per data set. It is intimately generalizable. I mean, we are the whole nation's data, so you can't argue with that. This is a great preliminary data, showing what's the impact of hepatorenal syndrome in your grant application. This is a large impact, but because of the lack of specificity, I would argue this is limited to hypothesis generating, which is let me take it back. I talked on the other side. So the pro is, as I look at these data set, you can think about a lot of hypotheses. Why is this? Why is that? Dialysis important, hepatorenal. So it generates a lot of questions. So that is a good thing, that it gives you a lot of hypothesis generating. I jumped to this, but it's only limited to hypothesis generating. There are many questions that you raise from data set, but you can't answer with this data set. Other cons, available variables. So I wanted to know creatinine values to see if they have hepatorenal syndrome or not, but this data set doesn't give you that. So in order to answer that question, you need a different data set, or you need to go out and get your own data. Accuracy, validity, you don't know. This is what you're given. And then in order to muddle through all these numbers, you need to know your statistics yourself, or you need to work with somebody who does. So those are the pros and cons of this type of data set. But the p-values, the reason I didn't show p-values is because I didn't feel that p-values is informative. These are the determinants of statistical significance. If you have effect size, that's what you want to get at, how different the two groups are. It looked very, very different. But if you have large enough sample size, you can demonstrate significant p-values for the differences that may not be that significant. And then the data variability, if you have a large variable data set, then it is difficult to demonstrate significant p-values between different values. So again, statistical significance is not the same thing as clinical significance. When you see two-fold difference in the length of stay, I don't care if its p-value is significant or not. In this data set, which is a universe of the hospitalizations, it's significant. You need to think about multiple comparisons, adjusting for p-values, and more importantly, small p-values don't redeem a poor study design. You put together a study, you see a p-value that's less than 0.01, voila, you have a great study. No. If your study sucks, p-values doesn't matter. So that is an example of sort of a descriptive study, but limited to what you can do with large data sets. I would argue that you can go a step further and try to talk about addressing some of the hypothesis testing. So the second project I'm going to talk about is impact of fatty liver on mortality. So we use NHANES-3 data set and NHANES-3 linked mortality data. This is all, NHANES is an all adult, we took all adult data proportion from NHANES data set between 88 and 94, which is NHANES data set. The unique part of that is had ultrasound examination to allow steatosis assessment. That the original idea was they wanted to look at the gallbladder, and they happened to have all the ultrasound tapes. So they went back and looked at the tapes and graded the liver echogenicity to tell if they had steatosis or not. And then the NHANES-3 linked mortality part is they were able to follow these people forward until 2006. So we looked at NAFLD as a part of this ultrasound examination. Then we were able to exclude alcohol and other etiologies based on the remainder of NHANES data. And then we determined advanced fibrosis in NAFLD based on some equation that has been published before. So again, we looked at the nationwide picture of NAFLD. We said 34% of the ultrasound showed steatosis. Again, big number. And out of those people who had steatosis, when we applied the advanced fibrosis equation, about two-thirds had low probability of advanced fibrosis, 10% intermediate, and 1% had high probability of advanced fibrosis. So this number looks small, but if you project it out to the whole population, 44 million American adults have NAFLD, and about 2 million Americans have advanced fibrosis. So great. I mean, this is a great thing to show for your significance section. But the hypothesis testing is a little bit here. We wanted to look at the impact of NAFLD on mortality. The survival part, the data came in with a 15-year follow-up data, so it's pretty significant. If you look at mortality, about 10% people died of cardiovascular, 5% malignancy. Liver mortality, even in spite of the large denominator, was only 0.4%. So when we did a Cox model and looked at all NAFLD patients and see what they died of, then all-cause mortality compared to people who did not have NAFLD, NAFLD patients had 0.97, meaning there was no difference. And it had no impact in any of these categories. Just having just fat in the liver didn't affect their mortality. So that may not be so good for your preliminary data because it undermines the significance of NAFLD. So you may not want to show that. But when we looked at people with NAFLD with advanced fibrosis, then it became significant. It increased the risk of mortality by 80%, significant. But what was interesting was you would think that the mortality would be driven by liver disease because they had advanced fibrosis, but we could not see any signal of that. The mortality was driven by their cardiovascular processes. So this is something, right? This is close to testing some hypothesis. So I think this makes the contribution to our knowledge. 5? Okay. So in order to do all this, you need to know statistics. And there are two parts. One is statistical knowledge. So you need to know what test to apply, right? And then the second part is actually doing the statistics, which means you're able to use the statistical package. So those are the two parts. And the second part is practically important because I strongly believe that if you are developing a research career in epidemiology, clinical epidemiology, or effectiveness research, I think you need to be able to program. So software, you need to pick carefully. I prefer packages that allow archiving of what you did. So something that you can pull back and rerun the analysis at a later time. People use Excel to do analysis. When you have 100,000 rows, it's practically impossible to use Excel for the analysis. But at the same time, once you do a point and click and change and sort and whatever, then you can't undo it or you can't reproduce it easily. So that's the limitation. One comment about biostatistician partner and mentor. I worked with a great guy, Terry Thorno at Mayo, that was my mentor. And the lesson that I learned interacting with him is that don't think of biostatistics as a p-value vendor that you go to 2 weeks before DDW deadline. That never works, and that backfires. He or she will never talk to you again. So this is a relationship that you need to nurture. It needs to be a scientific collaboration. They don't provide service to you. This is a equal level partnership. And then this is a two-way street. You provide something and you get something. It's respect, commitment, and time. So I'm going to talk briefly about this third project. This is the donor risk index. And donor risk index for people who do transplant hepatology is an indicator of how good the liver is. Okay? So this is a numerical system that has age, donor race, donor height, cause of death, type of donation, and partial versus split. And you notice that there is a race. And the question is, are black livers really not as good as white livers? Because there's a 20% embedded risk associated with African American donor. And that's an interesting and significant question. So we decided to look at it using the UNOS data. And the alternative hypothesis that we had is maybe it is a transplant center. The centers that have a lot of black donors, maybe inner city centers that don't deliver as good a care as some of the other hospitals. We looked at that. So we stratified our data analysis by the center information. And then what happened was when we looked at donor race, the effect went away. So at least on this ground, it's a confounding that should not be in the index at all. And it is still being used as an index of quality of livers. The other hypothesis that we had was maybe there's an immune system difference between races, and if you give a liver from one race to the next, there may be heightened immune interaction that makes the donor, the graft function poorly. And when we looked at the recipient donor pairs, it was interesting that if a white liver goes into the black person, the risk was higher, 1.2, whereas if a black liver goes to non-black, non-white liver of the recipient, the liver fared much better than their concordant pair. So all of this didn't pan out, but the center effects seem to be real. But just an example to show that this large data sets could be used to test some hypothesis if you carve out the hypothesis carefully. So where to start? This is the last slide. You need to pick a mentor. We talked about mentors so much. But for this context, it was helpful for me to have a mentor with expertise. Mentor may give you an access to existing data. I assume Dr. El-Sarak and myself and some of the others, Dr. Inadomi, have a library of data sets that you don't need to purchase again and give access to you. Resources for statistics and connection to other people. But I can't overemphasize you need to start collecting your own data because, again, these secondary data sets are hypothesis generating and they are preliminary data. It's good for early publication. You can get 5 to 10 publications based on these data. Easy, make your CV look good. But that doesn't translate to sustainable funding, unfortunately. So that's where I will wrap. I had some slide on the big data bioinformatics, but I will just skip through those. And these are just emphasizing what I just said. So thank you for the opportunity to participate in here, and all the best to all of you guys.